Welcome back to another episode of HealthCap Weekly Wrap.
Yeah, we're so glad you're here. There's a lot happening across senior living this week: tech innovations, new research, policy updates. It's one of those episodes where every story really ties back to improving quality of life for residents and supporting the teams that care for them.
Totally. From smarter move-ins to rethinking how we diagnose dementia, and even how AI is shaping care decisions, it's all connected. So let's dig in.
All right, let's start with a pretty exciting tech update. PointClickCare just launched a new product called Senior Sign. And this isn't just a software tweak. It's a full reimagining of the resident move-in process.
Yeah, so with Senior Sign, communities can now digitize all of their move-in documents. That means instead of printing out 20 different forms, asking family members to come in and sit down with a pen and clipboard, you can send everything ahead of time via email or text. They review it, sign it electronically, and boom, done.
It's fully integrated into the EHR too, right?
Yep. That's a huge part of why it works so well. Staff don't have to track documents across different platforms or manually enter things twice. And we're not just talking convenience here. Some communities are reporting up to 60% less time spent on admin tasks during move-in.
Wow. That's not just time saved. It's time reallocated to relationship building, which is so important on day one.
Exactly. Think about the difference between a resident walking into a lobby where staff are heads down in paperwork versus being greeted by someone who's been freed up to actually focus on them.
And you only get one chance at a first impression. For families who might already feel anxious or emotional about this transition, that personal connection can make all the difference.
Yep. It's a great example of how operational improvements really do impact emotional well-being. All right, shifting gears, there's this article from Medscape that really stood out to me. It lays out a better, more structured approach for diagnosing dementia in primary care, and honestly, it's super relevant for anyone working in senior living.
Okay, interesting. So what's different about it?
Well, it breaks the process down into 3 clear steps. First, the provider should do a quick, validated cognitive screening, something like the mini-cog or even a brief memory test that's easy to use during a routine visit.
Got it. So starting with something simple that fits into a regular appointment?
Exactly. Then step 2 is where it gets really important: gathering information from someone close to the person. That might be a family member, or in our case, even a caregiver or staff member in the community who's noticed subtle changes.
Yeah, that makes sense. Residents aren't always aware of what's changing, or they may not say anything.
Right. And the third step is to rule out other causes. So things like medication side effects, sleep disruptions, depression, infections, because those can mimic dementia symptoms.
Wow, yeah, I feel like we've all seen that. Someone seems cognitively off, but it turns out it's a UTI or dehydration or something.
Exactly. So the idea is to not jump to conclusions, but also not wait too long to act. Because if it is dementia, catching it early means more time for planning, support, and smoother care transitions.
Yeah, and that can totally change the experience. For both the resident and their family, you're not scrambling after a crisis. You're building a plan before one happens.
Right. And it gives the care team clearer information so they can adjust everything from daily routines to medication management.
That's so helpful. I think sometimes we think dementia diagnosis is all about specialists and imaging, but this really shows how much can be done in a primary care setting with the right tools and collaboration.
Exactly. It's practical, it's scalable, and it really empowers frontline teams to be part of the process.
All right, let's switch over to something legislative. Congresswoman Marilyn Strickland is leading a bipartisan bill focused on intergenerational caregiving, and honestly, I think it hits a nerve for a lot of people in this space.
Yeah, so this bill is aimed at supporting folks who are raising children and caring for older adults at the same time, which, as we know, is a growing demographic. It would provide financial support, better workplace flexibility, and more access to caregiver services.
And when you think about the workforce in senior living, this is a big deal. So many of our team members are caregivers at home and caregivers at work.
Exactly. We're talking about people who are working 8 to 12-hour shifts. then going home to care for a parent with mobility issues or dementia, or helping their kids with homework. It's exhausting.
And burnout is real. Support like this could improve retention, reduce stress, and help people feel like their caregiving, both professional and personal, is being valued.
Yeah, it's not just about money, it's about being seen.
All right, let's get clinical again. There's a new study, Inspire 3, that looked at how decision support tools impact antibiotic prescribing in hospitals, especially for patients with skin infections.
Oh yeah? What did they find?
So, the tool was designed to guide clinicians treating skin infections. Specifically, it helped them determine whether extended spectrum antibiotics, those really powerful ones, were actually necessary. And in a lot of cases, the answer was no.
Interesting. So the tool basically pushed back against overprescribing?
Exactly, and here's the thing. When providers followed the tool's recommendations, they used fewer broad-spectrum antibiotics without any increase in ICU transfers or hospital length of stay. Outcomes stayed stable.
Wow, that's impressive. So you're reducing risk without compromising safety.
Right. And that's where this gets super relevant for senior living. Overuse of antibiotics, especially broad-spectrum ones, can cause real problems in older adults. We're talking C. diff infections, resistance, kidney issues. So if hospitals are getting smarter upstream, it directly impacts resident safety post-discharge.
Yeah, that makes total sense. If residents are coming back from the hospital with fewer complications, that's a win for everybody. Families, staff, and the residents themselves.
Exactly. It's one of those subtle shifts in acute care that could have ripple effects across the entire care continuum.
So while we're on the topic of clinical tools, I want to talk about something a little more controversial. AI-driven decision tools like NarxCare.
Oh yeah, I've been hearing some buzz about that lately. What's going on?
So NarxCare is a tool that assigns risk scores to patients, usually around opioid use, based on a bunch of different data sources. Sounds helpful in theory, but here's the issue. No one really knows what's inside the algorithm.
Wait, so providers are seeing a score, but they don't actually know how it was calculated?
Exactly. It's a black box. The algorithm is proprietary, which means clinicians have no transparency. And yet, those scores are being used to make real decisions, like whether or not a patient gets pain medication.
Wow, that feels risky, especially if the score's off. Or biased.
Right. And that's the big concern. Without oversight or standards, these tools could be introducing bias, age bias, racial bias, even just data errors, and influencing care in ways that providers don't fully understand.
And in senior living, where medication management is already complicated, that could really muddy the waters.
Totally. You've got residents with chronic pain, multiple diagnoses, and maybe some cognitive impairment. Layer in a tool that flags someone as high risk based on who knows what, and it could lead to undertreatment or even stigma.
Yeah, that's not okay. I mean, tech should support care, not override it.
Exactly. There's real potential in AI, but we need regulation, transparency, and a way for clinicians to question the score. Otherwise, we're just handing over clinical judgment to a mystery machine.
Yeah, it's a big reminder that just because something's high-tech doesn't mean it's high trust.
Okay, now for something a little more uplifting. Mather Institute released a flyer on social wellness, and honestly, it should be required reading.
Totally agree. It's not just fluff. They've built a framework around 7 dimensions of social wellness, and they back it up with real research. Things like connection, meaning, autonomy, and contribution.
So it's not just host more events. It's, are your programs actually fostering real relationships and a sense of purpose?
Exactly, and that might mean intergenerational programming, resident-led groups, consistent mealtime seating, all these subtle things that build a community where people feel known.
And that impacts everything: depression, cognitive decline, even physical health.
Yep, social wellness is not just a quality of life issue, it's a care issue.
Last one for today. CMS has removed focused infection control surveys from routine inspections. They'll now only conduct those in response to a complaint or concern.
So, no more proactive infection oversight?
Not unless something triggers it. And understandably, a lot of experts are worried about that. Those focused surveys were put in place after COVID, 2, ensure communities were maintaining strong infection protocols. Without them, it'll fall to each community to self-monitor.
Which means operators need to stay sharp. Internal audits, strong infection control training, regular spot checks. All of that becomes even more critical now.
Exactly. You can't wait for a citation to find out there's a gap.
All right, that wraps up our stories for the week.
Yeah, thanks for sticking with us. As always, if you want to read more, we've got all the links in the weekly roundup on Angie's blog at healthcapusa.com/Angie's-blog.
And we'll be back next week with more updates and insights to support your work and your residents.
Take care, everyone.